So this is my talk, Teaching an Old Dog New Tricks. So the ketogenic diet we know has been around for about a century. There's been a bunch of talks earlier on about the use for seizures. I guess you could say it's more than a century, as Hippocrates was discussing it. I sat through a lot of boring talks throughout my undergrad, throughout med school, so I put a lot of pictures in to try to not make it boring. So this is kimchi and bone broth, which is my favorite food in the entire world. And this is an unfortunate MRI of a massive glioblastoma. So briefly, my talk today is going to be on the ketogenic diet, and I'll be real brief on that because this is obviously a very different audience than I'm used to. The history of diet and cancer, kind of where we got, or how we got to where we are, the pathways of what the ketogenic diet affects, and that'll be very brief, so don't worry. And then the rationale of the ketogenic diet from here on moving forward. So this will be my basically my only slide on the diet, and I'm going to be quick on this. It's a less than 20 to 50 grams of carbs per day and 70 to 80% fat. That's obviously very individualized. Some people need to be even less than that. Some people can be on the high end. 50 grams is somewhat high. It does result in often extreme lowering of blood glucose. And as we talked about in Dr. Sheck's lecture, that's not always the case. It aggressively lowers insulin, the IGF pathway, which Gene Fine talked about earlier, and it upregulates AMP kinase. AMP kinase is kind of the new kid on the block. So I'll discuss that as well very briefly. Ketosis does not equal ketoacidosis. I can't say that enough. The liver makes ketone bodies, and these can cross the blood-brain barrier. So they're an evolutionary source of feeding our brain energy. They're also an evolutionary source of when we're starving, when we're fasting, or in the winter when we're not eating carbohydrates and we start to digest ourselves. We digest fat, we digest glycogen, we digest protein, and we digest our muscles. Two muscles we do not want to digest are the heart and the diaphragm. If we digest them, it could be fatal. Ketones help us to not do that. They're oxidized in the TCA cycle. This releases acetyl-CoA, and then from there on we make some energy. In the brain cells, again, ketones are an evolutionary energy source. Tumor cells are less able to use ketones based on a bunch of data that's coming out. That's of course not absolute, and it's been safely used for over 100 years. For seizure treatment, and as Dr. Feynman spoke about earlier in several other studies, it's a very, very good diabetic treatment. It can cure type 2 diabetes in, I think, about a week. This is what it looks like. This is from a paper I published with our patients on a ketogenic diet. Again, lots and lots and lots and lots of fat. This has a decent amount of monounsaturated fat from all the olive oil. Dietary fibers, okay. And you'll see here the protein's a little high here, but this person was rolling steadily in ketosis. So again, these are very individualized. Some people can eat higher protein than others. Some people need lower protein. And just a heads up, I know I'm speaking a little fast because I want to try to get this done early to leave extra time for questions. I feel like every ketogenic diet talk, there's been people waiting in lines for questions. And now I'm up here so you can ask me and I'll give you my opinion. So where did this all begin? For me, and I guess for all of us, this started in 1909, and this is with Mareshi. This is the first study I know about, the first study that was at least published in a journal that I don't know how to say that, it's a German journal, but back in 1909 he took 4 groups of mice, and prior to implanting a sarcoma, which is a soft tissue tumor, he put them on several different diets. Feed intake grams per day, 1, 1.5, 2, and then ad libitum is when you can eat as much as you want. Obviously, the mice on the most restricted diet lost weight. The mice that ate as much as they wanted to gained weight. But as you see here, the tumor weight goes up the more they eat. So if you restrict the calories, the tumors don't grow. And this was the first study. Again, this is over 100 years ago. And it's pretty impressive that he was thinking that far in advance. Not long after, Peyton Roos from the Roos sarcoma virus, he's a first one to show us that a virus can cause cancer. He got a Nobel Prize for that. He liked this study. He liked nutrition. He tried to do it more so the treating physician would encounter how they would encounter a patient. So after diagnosis of cancer, the diet was changed. So he put it in first and then changed the diet, saw the same thing. There's slower tumor growth in diet-restricted mice, and that was about 40%, 30 to 40% calorie restriction. Over the next 40 years, Albert Tannenbaum these guys all worked together. He worked with Renato Basurga, who found the IGF receptor, who Gary Taubes talked about in his book. He did all these studies, and he was very particular about it. He weighed the mice constantly. He weighed the protein, or he looked at the protein, he looked at the carbohydrates, and he looked at the fat. So that's important. He's the first one, and again, this is in 1947. He's the first one to say it's more than just calories. It has to do with what kind of calories. And so you could see this is what he presented to the New York Academy of Science. These are the effect of underfeeding on the incidence of tumors. In the black line there is, the top there is how many of them got cancer. The etched line is how many got cancer when calories were reduced. The C's in an F means the type of calories he was restricting. The C's mean carbohydrates, and it's very obvious to the eye here that when you restrict carbohydrates, you see much decreased risk of the incidence of tumors. So to me, these are the first studies that start showing that it's not necessarily calories overall, though they obviously play a part, but within those calories, carbohydrates are important. And another contemporary during the time, take note of that, 1928, is Herbert Grace Crabtree. We heard a great talk earlier, several talks about the metabolic issues of tumors, about the history of cancer from an evolutionary point of view, thinking back to unicellular organisms when there was no oxygen around. Crabtree thought the same thing. He started to look at pathological overgrowths, and he saw the same thing. So yeasts, bacteria, these kind of things are taking up sugar, spitting out a bunch of junk, and then just trying to grow. And he actually made up the Crabtree effect, and we have him to thank for that, for all the wine drinkers in the audience. He was the one to show that if you dump a bunch of sugar in the yeast that make alcohol, they eat it up, and then they spit out a lot more alcohol. And it's actually considered a defense mechanism by the alcohol. It kills all the other things around it and then eats up all the sugar. So contrast that with what we heard earlier. It sounds like these cancer cells, or excuse me, it sounds like those yeast cells are behaving a lot like a cancer cell. His next paper a year later, he obviously saw the same thing, the observation on the carbohydrate metabolism of tumors. Basically the same paper. I mean, look at it. You can't even tell the difference. Saying a similar thing, one looking at yeast, these simple organisms, and then one looking at cancer cells. And again, this is how long ago that was published. So keep this stuff in mind when docs or other people tell you that there's no data on the role nutrition plays in cancer, because there's quite a bunch. So moving forward, why is this happening? So what about our cells favors carbohydrates either causing cancer or allowing cancer cells to grow? I won't talk too much about it because you've heard several talks already discussing this. So there's a couple things here. This is our mitochondria, powerhouses of our cells. These blue lines, anything in there represents aerobic respiration. That means oxygen is present. This is fermentation. That's alcohol, ethanol. Anything in here is when when oxygen is not present. And you see the overlap with glycolysis. So you can, whether it's present or not, you can do glycolysis. That's a breakdown of sugar. So that's the first thing here. Step number one, if there's sugar in the diet, you break it down into pyruvate. You can make some lactic acid depending on what you're doing. And then that's how you make energy from that. Totally opposite to that, those are the bones I use to make that bone broth, is fats and other foods that you can, when oxygen is present, you suck those in, they go on the Krebs cycle. It's quite an efficient process. Yet you start to see fermentation. That's Serge Ubray, for those of you that have seen Pumping Iron, and that's a crab for cancer. You start to see the same thing happening. These pathways look very, very, very similar. They overlap, and that's from a 90,000-foot view why some people would say eat fat, not carbohydrates. Craig Thompson, the chair of Memorial Sloan Kettering, basically made that basic comment. And again, with ethanol, with alcohol, you start to see the Crabtree effect. So take into account what Dr. Seyfried talked about, what Dr. Fine talked about, what Travis talked about. You're starting to see this whole picture. This is kind of the joining of all those things. Why does that happen? This is a paper I wrote with Renato Basurga. Again, he's the one that found this guy right here, the IGF receptor, an awesome human being. We wrote a paper on why is this happening. We went through all these studies that I'm talking about here to say why does nutrient restriction deprivation, why does it affect radiation therapy? And I'm a radiation oncologist, so obviously that's what we're looking at. But really what we talk about is why does it affect cancer in general, and why does it affect any treatment of cancer? And this is the most complex of the pathways I'm going to show. If you can remember one thing, it's remember that. So if you have insulin, which again, Gene Fine talked about this quite a bit, glucose or IGF-1 rolling around in your blood, they all can bind to this receptor, PI3 kinase, and turn on cell survival, cell growth, and inflammation. So that's why in these mice in Tannenbaum study, if you restrict carbohydrates, you see downregulation of that. In Gene's study with the advanced cancer patients, you restrict carbohydrates, you see a downregulation of insulin in the insulin pathway. This guy right here we'll talk about later. These lightning bolts were the crux of the paper. They overlap with radiation. So if you do these dietary changes, in theory that can make these cells more sensitive to radiation. And ecological studies are the lowest in terms of how sound they are in regards to kind of data or whatnot, but I find them the most interesting, so I'm going to have a lot of them in this. This is J.A. Urquhart, who was the district physician for the Eskimos back in the 1930s. He lived with them for 7 years. He had an x-ray machine. A lot of them get appendicitis. He did surgery on them. He had all the medical technology of the time and says, as regards cancer, I have not in my 7 years experience in the North seen a single case of malignancy in either Eskimo or Indian. As for the hospitals, the natives appreciate them to the utmost and use them freely. It is for someone else to explain this absence of cancer amongst these people, and that's what we're all here to explain. Interesting, a lot of people think it's because we know they're on a ketogenic diet. It's been some controversy of how many ketones they're actually making. They're clearly obviously on a low carbohydrate diet. So then the next question is, so we know why these diets could lead to cancer, so why do they allow cancers to proliferate, to metastasize, to continue to grow, to overcome radiation, and to overcome chemotherapy? This is Otto Warburg, and everyone always shows him in this like scientific lab. Or, I mean, if you take a picture with a poodle, like someone has to show this. And I mean, no disrespect to him, but this, come on. So he showed that glycolysis happens regardless of oxygen. I'm not going to go too deep into this. I have one more slide. We've already discussed it. Newer data is showing, obviously it's not just glucose, it's glutamine as well. This is for ATP production, which doesn't totally make sense because it's not the most efficient way to do it. It's also for biomass production. These cancer cells are growing. They're just becoming larger and larger. They're becoming tumors. They need carbons, and they're pulling those carbons from the glucose. They're pulling some purines from the glutamine. And also, glycolysis is upregulated to fix cellular damage. And that's the next thing I'm going to touch on. And that's in the field of therapeutic oncology, that's a very important area. And this is, I think this is Craig Thompson and Lewis Cantley. I've stolen this picture so many times and not given them credit. So I don't even know if it's theirs, but if it is, thank you. So this is the Warburg phenomena here, basically in a nutshell. If you have differentiated tissue, so this is normal tissue. Now it goes straight down here. So think of a muscle in your quadricep. You're running from a tiger. This is 1 million years ago. You don't have oxygen going to the muscle because they're pumping away. You make lactic acid. So that's what you feel, that burn. Now if you give this area oxygen, glucose goes to pyruvate, they bring it into the mitochondria. It's the powerhouse of our cells. It's the most efficient way to make energy. You get 36 moles of ATP per mole of glucose. Again, when that oxygen's not present, it's not very efficient, but again, it saves you from being eaten by that tiger. So evolutionary, it makes sense that this approach exists in our cytoplasm. So now when you look at Warburg over here, you take that, whether you take a proliferative tissue or a tumor. So for whatever reason, and there's a lot of reasons, it's beyond this talk, whether oxygen's present or not, it still breaks that down into lactate. So even though that's less efficient, and these numbers are rough numbers, no one knows an exact number. It still breaks it down into lactate. It still makes many less moles of ATP. From that mole of glucose. So it's very inefficient. One thing to keep in mind though, if we go back to that glucose pathway, so for those of you that took biochemistry or organic chemistry, and when the glucose is broken down, this is that pathway, so remember going down there and then into there. This side channel here to make ribose 5-phosphate, These are antioxidants. So cancer cells have faulty mitochondria, and this is to varying degrees. One of the systems of our mitochondria is a glutathione system, and that makes antioxidants. So when we're barraged with free radicals, that's how we fix them. Cancer cells rely on glycolysis to make these guys. These are antioxidants. So if you block that, you're going to block this, and cancer cells are going to die. How to do that's a little more complex than that. So we discussed how cancer can be started from those kind of diets, and now we're discussing how it can be fixed and progress and grow, because that's how it's going to overcome damage. And that's why, this is from a paper we wrote, that's why if you do carbohydrate restriction, but really if you block glycolysis, your normal cells are going to upregulate their mitochondria, Krebs cycle is going to kick in, they're going to make ATP, and they're actually going to have increased protection to oxidative stress. That's a whole other issue. That's one of the potential benefits of fasting, even periodic ketosis or ketogenic diet in people that do not have cancer. And this is based on preclinical data. Now, malignant cells, on the other hand, have an inability to adapt. BCL2, these pathways that keep them alive don't happen. Caspase is activated, and they undergo apoptosis. So they go a controlled death, basically a controlled suicide. This is partially how this thing right here works. That's a PET scan, and Gene Fine talked about those. That's just radio-labeled glucose that the cancer cells take up. So cancer cells like sugar, and that's how we diagnose them. That's how we tell how aggressive they are, and that's how we tell whether current treatments even worked, is based on their glucose uptake. And this shouldn't be a surprise to many people, though it is. Crabtree and Kramer knew this back in 1933. So this is a paper they wrote, The Action of Radium on Cancer Cells, Some Factors Determining the Susceptibility of Cancer Cells to Radium. And one of those things is glucose. They knew when glucose was around, cancer cells can offset the damage from the radiation. And again, that's that side pathway. So if you bombard them with free radicals, yet there's glucose around, they're going to make antioxidants to offset those free radicals. Again, this pathway right here. So Kramer knew this, and he said, what can we do about it? And this is a study that's only a couple years later. He started experimenting with 2DG. That's 2-deoxyglucose. And what this does is it basically plugs the hole where glucose can be taken up in cells. So we can get our glucose plus or minus down by diet. We can get our insulin down by diet. It's never going to be zero. So this is one way to block glucose uptake. And I'm going to talk a lot more about how this will play into treatments now and how I predict it's going to play into treatments in the future. So the problem is, and this is where 2DG can come into play. Once this guy right here, AKT, once he's upregulated, basically that cancer cell is just totally addicted to sugar. And it will tell it to pull in as much sugar as you can get. So along those lines, the less sugar you can have, in theory, obviously, the better it is. You're never going to get that sugar down to zero through diet alone, obviously. So the next question is, as Dr. Seyfried discussed, what can we do to block that? Or is there some way to affect that AKT or to shut it off? So the next question is, how does this affect current treatment dynamics? And this is a paper that we did a couple years ago. This is a project from my old institution. We just wanted to make it simple. Let's do what Tannenbaum did. Let's do what these guys did 100 years ago. Let's calorie restrict by 30% in several mice. What we did is we gave the mice mammary tumors, we gave them breast cancer. Half of them got a dose of radiation. Sorry, a fourth of them got a dose of radiation, a fourth did not. This is not a therapeutic dose of radiation. It's enough to just slow tumor growth. Then half were on an ad libitum diet, and then there's two studies within one. There's a calorie restriction diet, and then the other group just did alternate daily fasts. So they fed whatever they wanted to one day, they fasted the next. So there's one thing to keep in mind here before I go further. This was what they were eating. Okay, this is a mouse chow. So it's about 70% carbohydrates. So again, when we restrict these mice by 30%, or when we fast them per day, is this calorie restriction or is it carbohydrate restriction? Probably a little bit of both. So what did we see? As Adrienne told you, the quicker these lines go up, the faster the tumors grow and the bigger they get. So the mice that ate the most ad libitum diet, their tumors shot right up. Acre radiation somewhat slowed that. 70% calorie restriction slowed it quite a bit. That calorie restriction with radiation slowed it even more. So that's probably not surprising to a lot of people in the room. Let's take a step back. This in itself shows that diet alone is obviously affecting the growth of these tumor cells. So whether it's an implantation issue, whether it's a growth issue, it's decreased. Metastasis are decreased as well. I don't show that data. It works synergistically with radiation, similar to what Adrienne showed us as well. The one issue with these mice is they did lose weight. We're watching this. Obviously, this is a concern. We've all discussed this already today. So the next question is, what about alternate daily feeding, doing a full day fast? And basically, you see the same thing. Ad libitum, no surprise. They grow the quickest. Radiation blunts it a little bit. Radiation alternate day feedings are about the same. Alternate daily feedings and radiation synergize to make tumor growth slower. Now, there was no comparison between these two because the numbers aren't big enough. But obviously, looking at the eye, those graphs can almost be superimposed, and the growth is clearly slowed. The nice thing here is that the weight, they initially dropped, but those mice caught up. So this may be a potential mechanism in humans that we could try, and some have tried it. There's been a study where they fasted around the time of chemotherapy, done out in California. So again, this shows us that diet alone does something, and diet certainly synergizes with radiation. Pathways, if you remember, I'm going to show it about 5 more times so you won't forget it, but that insulin pathway, the IGF pathway, these were those major parts of the pathway. And as you can see, this is from the ad libitum mice. Those pathways, the expression of them continues to decrease as you decrease their diet and as you cause some radiation. So these mice aren't being cured, but that's likely why the tumor cells are growing a lot slower. Those pathways, the IGF-1 receptor, the IRS pathway, PR3 kinase, and mTOR is another one which we'll talk about briefly later. They're all repressed from these treatments. BCL2, the gene that keeps cells alive, is the most upregulated in the ad libitum mice, and then as you go down here to the calorie restricted and radiation, they don't have any of those survival pathways, and they're ready to undergo basically apoptosis. So similar to that one study, these mice, these cells actually start committing suicide to a degree. One thing to keep in mind, and Dr. Seyfried mentioned this years ago, mice eat much more food than humans. So doing direct calorie restriction is not necessarily correct. I'm about 200 pounds. That's how much food I would eat if I was a mice. 30% calorie restriction if I ate 40 pounds a day would obviously be a lot more significant than it is now. I don't know what I eat, like 2.5 pounds a day. So that's where fasting may actually give another benefit in humans, or a hack for that would be a ketogenic diet. So again, this pathway, keep remembering that. Though these were the things that were affected by that study. So calorie restriction, mostly in the form of carbohydrates, downregulated all these pathways. And this guy right here, mTOR, which Gene talked a lot about, it downregulated that as well. So blood glucose correlates with outcomes in patients with glioblastoma. This is a study from Johns Hopkins. These are basically 4 different quartiles of blood glucose levels. So normal blood glucose, well, what they say a normal blood glucose level is about 70 to 100, and that's even arguable. These were groups, this was 80, roughly 92, I think. Actually, sorry, this was 92, and this was in the 130s. So if your blood glucose, reverse what I just said, this is 130. If your blood glucose was 130, your median survival was about 7 months. If your blood glucose was below 90, your survival was double that. Now, these survivals are obviously miserable, but doubling of the survival just based on blood glucose is certainly interesting. Now, this doesn't prove anything. This is a retrospective study. But again, the question is, why is that happening? Well, it goes back to these pathways. So if you're pulling in more glucose, you can fix the damage. So you can fix the free radical damage that's going on anyway in cancer cells. You can fix the free radical damage from radiation. You can fix the free radical damage from chemotherapy. So there's another metabolic mechanism going on here that needs fixed. And this is why we talked about metformin before. Metformin increases insulin sensitivity, which actually will upregulate AMP kinase and block mTOR. So it's all about blocking these guys right here. And there's several ways to do that. And then one way to downregulate them, of course, is decreasing the amount of carbohydrates and sugar in our diet. So while we don't have a lot of data in cancer patients, besides the 10 patients from Dr. Fine's study, we have a lot of data in non-cancer patients from Dr. Volek and other studies. looking at glucose and these glucose and insulin levels, and these are in patients with metabolic syndrome, diabetes, heart disease. This is a review from Adele Height where she tabulated a bunch of their data. Very low carbohydrate ketogenic diet, low fat diet. This isn't a surprise to many of us. Glucose drops in both diets. This is an unrestricted calorie diet too. And this is a low calorie diet. Glucose drops quite a bit, down to about 13%, but look at insulin. Insulin rolling around in your blood, binding to that receptor, upregulating cancer cells, drops by 50%. There's no reason to think similar changes won't happen in a cancer patient. There is some metabolic dysregulation going on with cachexia and inflammation, but still you would assume that insulin levels drop, and that's exactly what Gene Fine showed us. And look at all these other benefits. That's a whole different talk for a different day. And this is no surprise. I make my, she just turned 94-year-old grandmother listen to all my talks, and I see if she at least pays attention or falls asleep, and if she doesn't fall asleep, I know it's somewhat interesting. So I try to put in things that she'd find interesting. And when I showed her that last slide, she said, yeah, of course, like everyone knows that. I knew when I was a little kid. She's Southern Italian. If you stop eating pasta, you stop eating bread, you lose weight. And Leo Tolstoy knew that as well. This is from Anna Karenina, Count Vonsky. He had no need to be in strict training, as he had very quickly been brought down to the required weight of 160 pounds, but still he had to avoid gaining weight, and he avoided starchy foods and desserts. So what's going on there? He's cutting carbohydrates, it's decreasing insulin pathway. These are anabolic growth pathways. So they're anabolic, they tell our cancer cells to grow, and they tell our fat cells to grow. So it's not by surprise if you limit one, it's gonna help the other. So this is a study that I published. I was hopeful that a ketogenic diet in itself would severely lower blood glucose. So if your blood glucose is high and we can lower it, in theory, you can do better. And what we showed, we compared 50 patients with 6 patients. Now it was only 6, but this was in 2014. I think I wrote it up in 2013. At that point, those were the only number of patients we had for GBM. And this is not a study. These are patients that came to me on the diet or wanted to go on the diet, so we watched them and made sure it was safe. Again, not a clinical trial. We looked at all their different blood values and compared it with the 50 other patients. So this line right here is that limit from the DER study, from the Johns Hopkins study that I showed. Patients under there live significantly longer than patients above there. So this is before surgery. This is when they come into the ER with a seizure or some kind of symptoms. They get an MRI and they see that there's peritumoral edema. So there's swelling around the tumor. They put them on steroids. Steroids help to pull fluid out of the brain. They also help to put your blood glucose through the roof, so it's very unfortunate. And that's how high they are. After the surgery, before the radiation, when you get surgery, you're going to be put on more steroids, so you get more swelling. Your blood sugar goes up a lot more. So then this is all patients during the radiation. When I try to quickly get people off the steroids, it's not always so easy. And then these are our patients that were on the ketogenic diet. So you see where it's way under that value. Half of them were on high-dose decadrons. They're on high-dose steroids, and their blood sugar still stayed quite low. It was about in the 80s on average. Some of them dropped down extremely low. So we're clearly affecting it. Now, we're not going to get it down to rates where we'd like to see, below the 50s or whatnot, but it clearly affects it. And the maximum here was one guy he was a chef, and he would make all these elaborate ketogenic diet meals, and he just had a ginormous binge day the one night, and he still didn't reach that point. So hypothesis generating for sure, but at least it shows we can offset that blood glucose rise. Now, can we add this to some other metabolic treatments in the future? Obviously, that's the hope. This is a ketogenic diet that, it's like that pie chart I showed you from one day of my patient. Now again, the protein is high. He was still in ketosis, so not too bad, right? I wrote this up because the dietitians were totally alarmed that people were on this diet. They said, where's the variety? They're not gonna get their vitamins or nutrients. It's so mundane. Like that's a pretty good day. That's a little high on the calories. That's kind of why I put it in there. So it wasn't always like this. But coffee, cream, 3 eggs, bacon, broccoli, Greek salad, olive oil, coconut oil, kale, salmon, and then a snack of macadamia nuts. So not too shabby. Again, if patients get creative and we support them appropriately, we can make it quite easy for them to go on a ketogenic diet. And so what happens when they go on this diet? This is gene study. Ketone levels go up and insulin goes down. So we have patients now on studies where we're giving biologic agents that bind to insulin, the insulin receptor, and lower it. They block insulin. This is basically doing the same thing through diet alone, and it's quite safe. A lot of these these drugs that block insulin cause severe hypoglycemia and can be symptomatic. You're not going to get hypoglycemic symptoms if you're creating ketones. I've personally had my blood glucose go quite low. The Cahill studies back in the day, I forget what number he had people down to, but he was giving them insulin and their blood glucoses were so low that it's shocking to see. And then Jeff Volek, who again, unfortunately he's talking right now, he'll tell you on his ketogenic diet studies, he has people in the 30s that are asymptomatic. So you can block it. If you have these going, it's going to be there's going to be a lot less side effects, and that's something that we need to keep in mind. If this diet can offset side effects of some treatment or metabolic treatment, that could be quite powerful. And last but not least, now this is an animal study, but this is from the group out in California. These are mice that didn't have cancer. It's a cruel study. They gave them etoposide until they died. So again, it's a cruel study. And then a bunch of them, they did different things. They did fasting, they did calorie and carbohydrate restriction, and they showed that you can give doses that are lethal to about 60% of mice. And if you block glucose or you put them on a ketogenic diet beforehand, that chemotherapy doesn't kill them. So what this is saying is that it may be an escape mechanism for our normal cells to offset the damage from chemotherapy in this case, but radiation therapy as well, or maybe other metabolic treatments. And these are just more graphs where they upped the dose of etoposide here, so all these mice died. And then they took the same dose of etoposide, but they fasted the mice even longer, and then 100% of them survived. So it's one thing looking at it therapeutically, and of course I'm very hopeful that the diet in itself will be therapeutic, but if it saves us from toxicities of other treatments, perhaps it's another way to utilize a diet that we haven't really thought of. Why is glioblastoma always chosen for these studies? I get this question a lot. First off, because Dr. Seyfried, that's what he looked at first, so there's data on it. Dr. Scheck as well. One of the hopes for me initially, and because it's obviously treatment at this point is unsatisfactory. The other hope was that the blood-brain barrier could create a hyperketotic environment within the brain. So there's a lot of stuff going on here, but if you think about aligning around all the brain cells, they let things in and out, and they don't let some chemos in, which is why you have to give certain chemos when patients have brain tumors. But the hope was that if you put them on a ketogenic diet and the ketones are so high, the brain's going to start relying on ketones, it's going to shuttle them through, blood glucose levels are going to drop, and you're going to get a hyperketotic environment in the brain. There's some mice data to suggest this. There's a talk yesterday morning from some of the research that they've been doing with this. This is more controversial, but it's certainly one of the hopes that we could exploit that. And she spoke with you, she gave a great talk before, but this is certainly a study that opened a lot of eyes, obviously at her institution, and opened a lot of eyes at my institution when she put mice on a standard diet or on a ketogenic diet, and from the diet alone, again, the slower this drop is, the longer these mice live. There's a survival improvement, and this is really something that has not been seen. These mice were cured. You want that to flatline. That means no one else is dying, and that's from a ketogenic diet. With radiation, she went through the pathways. It's very clear that it sensitizes these cells to radiation. Radiation and chemotherapy is the standard of care. Clearly, it's not getting us where we want to be. Jeff both talked about that. Obviously, Dr. Seyfried talked about that. So the question is, first, can we make it better? And then from there, when we get to where we want to be, maybe we can peel some things away. So we're hopeful this will help. Again, I think other agents are going to come down the line. There's immunotherapy. where the diet may be synergistic. And again, the escape mechanism for our normal cells is something very important that we need to think about that we don't often consider. We don't have to get Goliath with the first swing. There may be a couple other mechanisms, a couple other ways to rally the troops. So there again in my bone broth. The ketogenic diet, it's in a sense, looking at these old studies, looking over the last century, it's like a calorie restriction mimetic. So as we go from mice to humans, it's like a hack. And in the cancer world, that's important because no one wants to starve patients. We do want to safely restrict them if we can, or we want them to fast, which may mimic calorie restriction. Ketogenic diet may do all those things. Now we got to test this out and look at some markers. But if it's a way to elicit the same response as fasting people or as doing a severe calorie restriction without actually doing that, it's much more feasible for patients. That's something we need to look at, and that's a big area for sure. It has similar biologic pathway changes, it has similar metabolic changes, but it has dissimilar physical changes. So that's the key there. It actually protects muscle loss. And along these lines, this is from 1958. This is a study where they actually gave exogenous ketones. So this is a hot area, and we've apparently been doing this for quite a while. Why didn't they follow up? I don't know. These are mice with leukemia, and these are doses of ketones that the mice were given. And as you see here, the higher the dose of ketones, the longer the mice live. So this is the first paper that I know of showing that you can simply eat ketones and it could potentially make you live longer. The question is this having an anti-tumor effect, which it very well may be, or is this having an effect where it's sparing the normal cells from the issues that are going on with the chemo, or excuse me, not chemo, with the cancer cells, thus allowing them to live longer? And we don't know, but this is, again, interesting as well. And it brings up the question, can we just give ketones? And we don't know the answer to that, of course. So the way I see it is this Venn diagram. So there's metabolic manipulation, and that's via glucose. I put plus or minus glutamine there because, well, I think it's important. I didn't have enough time to talk about that, so that's a whole nother talk for a different day. And that uptake blockade of those. Dietary manipulation, and that's carbohydrate restriction, plus or minus calorie, plus or minus protein restriction. Protein restriction can upregulate mTOR. And then there's energy manipulation, increasing keto availability. That's whether you're on a ketogenic diet or taking exogenous ketones. One thing that gets all those is the ketogenic diet. So I'll speed it up here. Last comment, AMP kinase. This is kind of the new kid on the block. This blocks mTOR. It's upregulated at least in our normal cells via intense exercise, fasting, and carbohydrate restriction. There's actually a study in humans where they did muscle biopsies where they showed that you can overfeed humans as long as you're cutting carbohydrates. So again, this may be a hack in our cancer patients to not restrict food, but just switch things up on the macronutrient profile. This does a couple things. It increases glucose uptake, so it pulls it out of our blood and into our cells, so there's less around for cancer cells. It increases the breakdown of that, stops gluconeogenesis, so it stops the production of glucose. Increases mitochondrial biogenesis. That's obviously important if mitochondria are helping us to fight cancer in the first place. And this, again, this is all for both treatment, but even and ideally preventative. Decreases mTOR, increases insulin sensitivity, which means you have less insulin floating around to bind to those cancer cells, and it breaks down fat and cholesterol so that you can use it for energy. So again, I can't stress this enough. I think the diet may play a big role in metabolic escape mechanism. So if we're blocking this major source of fuel for both our normal cells and cancer cells, we need to exploit the fact that our normal cells can use these guys. And again, that's whether it's exogenous ketones or a ketogenic diet. And I think as we plan studies in the future, we need to keep this in mind. So this is just kind of an overall carbohydrate restriction, intermittent fasting, ketogenic diet, exogenous ketones, get you into ketosis, can potentially mitigate toxicity of radiation therapy, chemotherapy, metabolic therapy, may synergize with radiation therapy, chemotherapy, who knows, even immunotherapy based on preclinical data. The question is, does it prevent cancer? And I think that may be where the biggest bang for our buck is, but those studies are nearly impossible to do in humans, so I wouldn't hold my breath on that one. I personally undergo a ketotic diet because of, I think, that benefit's there. Anyone know what these side effects are from? Ketogenic diet? No. So if you're a physician or a dietitian or have a loved one on a ketogenic diet, when they get these side effects, which happen from a lot of things, most likely the radiation and chemotherapy they're getting, they're going to tell you it's from the ketogenic diet. It's not. It's also from a ketogenic diet done very poorly. So if you're on a high protein ketogenic diet, you're not going to be making ketones and you're going to feel all these things. That's something to keep in mind. I'm going to speed up here to wrap it up. Everything I tell my patients to do except for radiation and chemotherapy, I do myself. And these are my first 110 finger sticks when I was on a ketogenic diet last year. I wanted to see where my serum glucose goes. Reiterating what Dr. Seyfried says, it's all over the place and it depends on a lot more things than diet. Adrienne, you stole my thunder, but does anyone know what those, well, those are my largest blood sugar levels, and those are from, anyone know what that's from? It's not what she said. No, that's from working out. So you're mobilizing glucose from your glycogen. Anyone know what those are from? Yeah, that's my morning drive to work. That's a 9-minute drive, puts my glucose through the roof. And I'm a pretty chill person, but in the car I'm a disaster. But one thing to note, you see how low it drops after exercise? So exercise brings it up, then you see how low it actually drops. And these are my blood glucose levels in the morning. You see there I'm in the 50s. And that was not that hard to get down there. I think if I was a little stricter on my diet, I could be. Here's my serum ketone levels. You see when I just started, I was kind of all over the place. Then I was rolling between 1 and 3. So I wasn't above 3. I do drink a lot of wine, and I think that had a lot to do with it. And obviously a patient wouldn't be doing that, but it's something to keep in mind. Like, it's all over the place. And why was I that high that day? I didn't know. There was no change in my diet. So that's something to keep in mind when these patients come up and they're stressed out. And as we move ahead with clinical trials, we need to realize this, because if we have strict guidelines on these, then patients are going to be getting kicked off the trials left and right, and they're going to say the diet's not doable. So do ketones have to be above 1 millimole at all times? I think that's probably more along the yes. Do they need to be above 3 millimole? I don't know. That's, for some people, that's very tough to get, and their diet is very strict. And I have some people that are actually calorie restricted that can't get that. So maybe it's stress, maybe it's a lot of different things. Does blood glucose matter? Probably, if we can't get it down. That's why I want to give other metabolic agents that can block it, where maybe it doesn't matter. Does calorie restriction matter? Again, we don't know these types of things. So those are the things I think we don't need to go nuts over. If we can optimize them, great. If not, oh well. So the ketogenic diet, supported by historical context rationale, significant preclinical data. It's safe, and people are doing it regardless. I get people seeing me all the time, and they're already on it. So we can either pretend they're not on it, or we can guide them and do it safely. And it may synergize with modern metabolic treatments. That's liver, lung, and heart. And I had it, is Ken Ford here? It was a restaurant he told me to go to, and it was the best meal I've ever had in my life, and it was definitely ketogenic. Last but not least, this is what we're telling patients. The hatched thing here is carbohydrates. These are from major cancer institutions in the country. Up in the Northeast, they're telling people to do a 95%, or excuse me, a 80% high carbohydrate diet. These are the old remnants of the whole heart issue. These are cardiovascular recommendations that somehow permeated into the cancer world. We don't know what exactly to tell patients, but we sure as hell know that that's really wrong. So that's why this is important, and we need to push forward with well-organized studies to answer these kind of questions. I want to thank the following. Rainer Clement, we email almost daily, passing things back and forth. Gene Fine as well, Jeff Folek, Adrienne, Q Collins, Dominic, I don't think he's in here, but I wanted to make sure his name was right, and I Googled it, and it's spelled differently at every site you go to in the entire world. Angela, thanks for inviting me. Dr. Seyfried, you were the first person to really become vocal and push this, so we absolutely have you to thank for that. Funding from other research is Misfit Activity Trackers and Kinetica Health, which is a patient tracking service, and my collaborators, Dr. Uri and Simone. Any questions?
If cancer is a metabolic disease, why do you think chemo and radiation are increasing life expectancy? And then second to that, if you had the option of running whatever study you wanted to next, what would you run? Being realistic that you can't go in huge exposure.
Yeah. So, yeah, I think those two questions are heavily interrelated. So, back in the 70s, the survival for GBM was in the single digits. And they did studies where they dose escalated radiation to 60 gray was kind of where they came up with. And they showed a survival increase. Now, this is not a satisfactory survival increase. We're talking months here. But it did add on. And then the most recent study with chemotherapy is the Stoop regimen from Germany, where it added about 3 months. Again, not massive by any means, but prior to that, it was a 12-month survival. So that was a big deal in the field. So it's clearly not satisfactory. What it's probably doing is blasting the cancer cells and knocking them back a bit until they grow again. So it's certainly not, it's curing very few people. There's literally single-digit reports of people that live like 10 years or more. So I think what it's basically doing is damaging the cells enough to add a couple months on, but rarely is it just getting rid of them so normal brain tissue is coming about and going from there. So then what is my study? So my study would be, which we have one right now going through the IRB, which you talked about yesterday, add a ketogenic diet to standard of care, which is what Adrienne's doing, with radiation and chemotherapy, knowing very well that radiation and chemotherapy at the end of the day may play a smaller role or may not play a role at all, and then adding on metabolic agents or immunotherapy even perhaps to stimulate our normal cells, to block all those things I talked about, and then once we show a benefit, then start peeling away on the more toxic types of treatment. So maybe we don't need radiation. Maybe we only need 30 gray of focal radiation, which would cause minimal side effects at all. But that would be a victory. So we don't know these things, so we need to ask these questions in a very systematic fashion. So Dr. Sheck's study is great because it's kind of the first thing there, but we need to be smart about what we're looking at too. If we think we're going to put people on the diet alone and immediately beat the hardest tumor we've ever faced in the history of the world, like, it's not going to happen. I hope it would happen. We need to be systematic about it. We need to take its legs off first and then take its arms off first and then go in for the kill. We need to see if it helps reduce toxicity, because maybe if it reduces toxicity of some of these metabolic agents, we can slam it with a new metabolic agent. But we need to be very systematic about it. And I think the diet probably has potential that we don't even know yet, but we need to start to assess it to figure out what that potential actually is.
Do you or others you've worked with have any history in studying the macrobiotic diet, and whether that has an overlap with some of the things you're observing now? For decades, that was known as the cancer diet, very restrictive diet, but clearly looking at a nutritional and metabolic approach to cancer as opposed to chemotherapy and radiation. Could you comment on that?
Yeah, I don't know of any study. I mean, the studies in humans with the ketogenic diet are so sparse. So with that diet from a couple years back, I mean, there was a clear, once the genetic view took over, I mean, like all those studies I showed you, like, why did they just stop, right? We're like 2D, I don't know where Kramer and Crabtree went. I don't know if you know where they just like disappear. They're running great studies, and so I don't know what happened, and maybe they just stopped funding their research. I don't know, but there's clearly a dark age of where there's just been no studies. It's weird you have to turn to the early 1900s to find these things. So I'm assuming that plays into it, but I don't know of any. I don't know if anyone else in the audience does.
Do you have any knowledge of how hypothermia might work in conjunction with the ketogenic diet and maybe potentiating radiation as well?
Yeah, so that's another, they do a lot of that at Penn because their chair was really into it, but the studies on that for any treatment are very limited. They do it for like gastrointestinal treatment, I know, but I don't know of any overlap, anything looking at overlap. And I wouldn't be surprised if it synergized with it. I mean, all those pathways we've seen earlier today, it would make sense to me. I just don't know of any data that I could say link the two. Sorry.
I think your point about trying to take the arms off and then sort of going for the kill is really good, and then trying to peel things back. Roger Stoop, the a clinician who created the standard of care for glioblastoma, wrote an editorial this past year, saying that in newly diagnosed patients who have an unmethylated MGMT promoter, that we should no longer be putting those patients on temozolomide, which is 2/3 of glioblastoma patients. And I think that's a really natural area to be focusing for peeling back, especially given the preclinical data that we've seen today and how much synergy there is with these diets and radiation. And there's some synergy potentially with temozolomide, but it's a lot less.
Yep.
And in those patients, they're not deriving any benefit from getting the temozolomide anyway, so we're just giving them an alkylating agent to give it to them because we have nothing else to offer.
I agree.
So if we're looking for agents to sub in for temozolomide, I would say that's probably the highest benefit potential group because you can go into the newly diagnosed setting.
Yeah, 100%. The other sorry, you were still going?
I have to add something here. A lot of people can't get into clinical trials unless they have done the standard of care. So that's why some of the people I work with actually subject themselves to temodars just to get into a trial.
Yeah, and so that's why we need to do studies with these agents showing they're safe, and then we can start peeling away. We're not just going to do an immediate study with a drug I pull out of my pocket. The other problem there too is when you do that, it could hurt, like we're trying to advance the field. So if you take the absolute worst of the worst of the worst and then apply this to it, if it comes back negative, they're going to say, see, it doesn't work. We're done with that now. So that's another reason why we have to be systematic about it and then show that, oh, well, or maybe it works with MGMT methylated, and then we say, okay, so let's do it with unmethylated and add something else to it. Yeah, I agree 100%. I mean, all the fighting that you had to do, there's clearly a pushback. So if we don't take, we're walking on eggshells here. If we don't take every step very calculated, they're going to say, see, or patients can't do it. So if we look at ketone level has to be above 2 or you're off the study, then they'll say, see, no one can do this study. We're not running anymore. So I agree with you. That was my long-winded agree. Yep.
Yeah, excellent talk. Thanks. I have a comment about calorie restriction in terms of just the use of the term at all. It's an extremely poorly defined term. When we say 30% calorie restriction, what you're actually accomplishing depends exquisitely sensitively on what the baseline diet is. And you should baseline diets all over the page, we recommend it's everything. General diet, 55% carbohydrate, 75% carbohydrate, in which case calorie restriction actually represents the fact of carbohydrate restriction as the principal reduction. So the idea of talking about calorie restriction as if it's an entity, I think it needs to be reconsidered. I just don't know what it means.
Yeah, the study, even Tannenbaum, who, he had 50 years of studies there, his range, it was all over the place. 30% one study, 50%. I don't even know how they were coming up with it. And he was the most calculated of the bunch.
Right. But I mean, I'm amplifying on the substitution that you pointed out to me about Tannenbaum, that his most significant effect, however, was when he restricted carbohydrate.
Exactly.
So
It's weirdly, and you and I, we talked about this in email. It's weirdly that was lost, like all the calorie restriction people, like somehow just glossed over that.
I think one of the things that's really critical with all the studies is daily measurements of blood glucose and blood ketones. And I say blood ketones, which is harder to do because the strips are really expensive. But urine strips, which people go, oh, they're cheaper, we'll do that. They're not accurate. And there's no way to really know if somebody is truly keto adapted unless you actually have the numbers, and it's almost irrelevant what they eat if you go person to person to person. The bottom line is what's there. We also have no idea what level is important, as you pointed out. Again, the only way to do that is to amass as much data as possible. You actually have the numbers, and you can get an idea. And I think that the numbers are going to vary depending on a person's individual tumors. Tumors have different genetic makeups, and by genetic, I also mean metabolic. So some tumors might respond to 2 millimolar ketones, and some tumors might not. They might need 3 or 4. And it's such an infancy level. I think it behooves all of us to get as much data as possible to press it out.
Yeah, and that study where I had to mortgage my house to pay for those ketones. I mean, it's like unbelievable. Yeah, and the price went up in the middle, so I couldn't stop.
You all order competitive, but to your points, calorie restriction. We'll talk about the dogs later, but we looked at normal weight, and the dogs to meet that was either 11 calories per kilogram to 39. So the metabolism is completely different. We compared the finger sticks to the urine, and there's very little correlation.
Right.
But when we tried to look at the value of the glucose and the ketones, or glucose ketone index, to a secondary surrogate marker, and we were using metabolic disease, there wasn't a good correlation. Those people who had the best ketones and glucose numbers didn't necessarily have the best effect on the metabolic condition. So there's a tremendous, intra-subject variability that until we get all that data, it's going to be hard to figure out.
Right, which is very frustrating because it's going to take quite a while to get that data. It's going to drive all of us.
As a clinician, do you see in these patients that you treat with the diet, without the diet, do you see wasting, like cachexia-like symptoms? And if so, what dietary/supplemental interventions would you propose as potential treatment for that if you do see it?
So GBM patients are more often, like I see more males, and they're often like around the time of retirement. They're not like your obese patients. Like they're, I'm trying to think of someone I could have mentioned, but I can't remember. Steve Sable. You guys know Steve Sable? He had a GBM. He passed away from it. That's like the prototypical. He like comes in and he's like, he doesn't have a lot of weight to lose, but he doesn't waste away. Like, I don't see wasting. I don't see cachexia for GBM patients really at all. I had a couple people that did severe calorie restriction during it, and then I saw it. And again, it's a whole entity. Who knows what they were doing right or wrong? It was like a 40% reduction. Then you see it. With the ketogenic diet, when it's done well, you don't see it. People lose weight, and the dietitians go nuts. But a lot of people have weight to lose. Like if you have fat on you, like I saw this guy, and they're like, he lost 10 pounds. And I'm like, awesome, he needed 10 pounds to lose, like high five. And they don't see it like that. So they extrapolate from the metastatic lung cancer patient who's, like you said, wasting away and has inflammatory markers through the roof. So, and Dr. Seyfried has spoken about this too. We need to differentiate cachexia from just weight loss. And a lot of people have, again, weight to lose.
Sure.
I once had a patient with glioblastoma, and she's a big-time alcoholic. And she eats a tiny little meal a day, and the rest of her calories came from alcohol. Actually, she got ketones in her urine. So is there any literature on this issue about alcoholics and cancer? Can you shed some insight?
I don't know. I know personally, I guess let me ask the question back to you so I know that I understand it. So you're saying, do people that drink have a higher risk of, you said she was producing ketones from the alcohol.
I forgot to mention, she actually is a 5-year survivor. I did not expect her to live that long.
Mm-hmm. With a GBM?
Yeah, particularly myself. So I and is that because of calorie restriction? Is that because of ketosis? And alcoholics, they go into ketoacidosis. And what happens to their insulin?
Interesting. So me personally, if I'm not on it, and I don't know of any data, so I can just speak of my own values because I follow them pretty closely. If I'm not on a ketogenic diet and I'm close to it and I go work out at the gym, and then after the gym I go with buddies to grab a drink, I always just start spewing out ketones, like through the roof. If I'm in a ketogenic diet and I have 2 glasses of red wine or more, my ketones drop down. And that's what I showed you guys. So I don't know. It's probably one of these individual things again. I don't know, but was she drinking red wine? No. Oh, all right. Damn it.
Okay, thank you so much. Great question.
All right. Thanks, everyone.